So my name is Dr. Teresa York, for those of you that I've not had the opportunity to meet, and I am the division head at Pediatric Hematology-Oncology at the University of Maryland. I've actually been at University of Maryland for 13 years, so it's the place where I've been the longest. And thank you so much for inviting me to come and speak with you today. This is a very broad topic, and basically, I just wanted to say, first of all, that I have no financial conflict of interest with any topics or products that are going to be discussed today. The learning objectives for today's grand rounds are to review the actual normal pathophysiology of hematopoiesis in the newborn period, recognize abnormal hematology disorders in the newborn period, and review of the current clinical practice for hematology disorders. And to be honest with you, I have been doing this for a total of 20 years, and I am still learning every day about our NICU consults, and something comes up all the time that we may not have entertained before, but we can easily figure out how to get to the answers. So my goal really with today was just to make you aware of some of the hematology disorders and maybe even discuss some of the clinical cases that we've cared for at University of Maryland. So an overview of the topics in today's lecture are developmental hematology. I'm going to focus on erythrocyte disorders, platelet disorders, leukocyte disorders, and then I thought I would touch on thrombosis and bleeding disorders, because these are the common questions that we receive in my office. And I'm thankful that Dr. Langbaum gives me credit, but I have wonderful colleagues, and I know Dr. Mankantange also has spoken with Dr. Langbaum, and we have Dr. Munchel and Dr. Park. So just to review some developmental hematology, normal hematopoiesis in the newborn period, it actually starts around days 16 and 19 in the yolk sac. Then the fetal liver hematopoiesis occurs by week 5 to 6 and lasts through week 22. And then your bone marrow becomes hematopoietically active around week 8 and eventually becomes the predominant site of blood production. So here is a diagram showing you how it first starts in the yolk sac, then we go to the fetal liver, and then eventually to the bone marrow. This is an overview of just sort of the timing again. Yolk sac in the beginning, liver and the spleen kind of helps out a little bit in the middle. And then by the time you're born, your bone marrow is the primary site. Then as you age, you can see that our vertebral bodies and pelvis are the major site of hematopoiesis. So interestingly, during my research for this talk, I actually did not know this fact, so I thought I would include it. So erythrocytes were the first blood cells identified with the aid of the microscope, and this actually happened in the late 1600s. But the colorless white blood cells remained obscured from observation for several hundred years until 1877. Do we have any medical students in the room? Hey, so this guy was a medical student, Paul Ehrlich, and he devised a triacid stain that actually permitted the identification of hematopoietic precursors, and specifically the white blood cell lineages, which opened up a whole new, information gathering. And much of what they learned about the development or hematopoiesis is, and this is horrible, but they used to give mice ionizing radiation, and then they would study how the bone marrow would recover. So that's how we learned about hematopoiesis. It's kind of weird, but that's what they did. This is an example of a normal peripheral blood smear, and I just want to call your attention to this is a normal neutrophil, and these are the red cells. This is a normal eosinophil, lymphocyte, monocyte, and basophil. And it was remarkable that they got this all in one screenshot. Because usually you have to look all over your smear and find examples of the different types of white blood cells. But this is an example of very healthy, normal peripheral blood smear. Also, the red cells are nice and round and very, they have that central pallor. That's an evidence of a normal red blood cell. Just to review very briefly, you have your stem cell progenitor, which you can have a myeloid progenitor, a lymphoid progenitor. So the myeloid progenitor cell line is much more complicated, and it differentiates to megakaryocyte, which then leads to your thrombocytes or platelets. You also have erythrocyte, mast cell, a myeloblast. The myeloblast further differentiates to the basophil, neutrophil, eosinophil, monocyte, and then the macrophages are from the monocyte line. Then over here in the other corner, you have the lymphoid progenitor cells, which include your natural killer cell, small lymphocytes, which are broken down into T, B, and then the B lymphocytes are related to the plasma cell. So basically, these are all the normal progression. So you can imagine all the disease states that happen when you don't have normal progression, or if you have an abnormal clone that develops along that development. This is a very nice slide showing you what a normal bone marrow aspirate looks like. And what you notice here is you should see a lot of different looking cells. These are all white blood cell precursors. These are bands. You can see very large monocytes. This is a megakaryocyte. They are the largest cell in the bone marrow. They can sometimes get confused with osteoclasts, but osteoclasts actually have separate nuclei, but they can look similar, but that's a common, they try to trip you up on that as on testing. So just remember, osteoclast has separated nuclei, whereas megakaryocyte is one huge nucleus. On this side here, you have a bone marrow biopsy, which this actually tells you about cellularity of the bone marrow, but we rely on the aspirate to tell us actual characteristics of each of the cells, because as you can see, you can look and see each of those cells more distinctively on this side. But this one tells you about overall cellularity. There's a spicule. These are fat cells, and it's nice and rich and sea of a purple, which is what you should see. Let's talk about the development of the immune system in a newborn, because it's very different. Newborns, we know, have a lot more vulnerability of infections due to immature immune system. The cellular component of the immune system consists of macrophages, granulocytes or neutrophils, same thing, and NK cells or natural killer cells. The adaptive immune system consists of your T and B cells, and they begin to function by the second trimester, but they are not at full capacity at birth. All of your major lymphatic organs and cell types of immune system are present by the 11th week post-conception. Neonatal macrophages have a decreased production of cytokines, therefore they have impaired phagocytosis. Neutrophils appear after macrophages. They are reduced in number, and they have qualitative impairments in migration, adherence, chemotaxis, phagocytosis, killing, and delayed apoptosis. Neonatal neutrophils also have a lower level of L-selectin, CD18, CD11b, which are molecules that are involved in neutrophil adherence. Defects in phagocytosis are due to the reduced levels of serum immunoglobulins. The natural killer cells, which are responsible for anti-proliferative effect on viral and or malignant transformed cells. Their function is also impaired at birth when compared to adults. Serum complement levels are low until the 3rd trimester. Then at term, they are still approximately 50% of their adult levels. Intrinsic immaturity in the signaling system of the T cells is also very immature, so they are very susceptible to enterovirus, herpes simplex, candida, toxoplasma. The B cells rely on functional T cells to help them with antigen-producing plasma cells, and cytokine production is generally reduced. So this is a nice diagram showing you what a leukocyte does in the body when it has all of the components. So here you have a leukocyte in the resting state. Then there is a step here where there's a rolling of the leukocyte that recognizes the foreign objects, and this turns on more leukocytes to come help out. Then there's a firm adhesion, and then eventually they go into the tissue infiltration to try to go and help and preserve and treat whatever infection that you're dealing with. So this is just a diagram of all the complexities that happen with leukocytes, and we know every step of the way that a newborn is impaired in their ability to do this. Also, we know that the development of the immune system, you have an antigen, you rely on macrophages, you rely on the T helper cell. These two types of cells are very central to immunity. And even the B lymphocyte relies on the T helper cell. So this is just a diagram of what I just read to you about the immune system in the newborn and how we really do rely on those T helper cells, macrophages, and the B lymphocyte to be able to recognize a foreign agent or an antigen that's trying to cause a problem and then be able to get rid of that infected cell. Also, we know that there are several interleukins. This is, we know that these cells are impaired and don't have the normal adult levels that we have at birth. So you have IL-1, 2, 3, 4, and if you notice, a lot of these are relying on T cells to produce them. And this also helps you to fight off infections. All right, so that's the overview of the normal hematopoiesis. So I was going to start with erythrocyte disorders since that seems to be one of the more common, and platelets are the other common one that we get a question about. So very common to see in our neonatal intensive care unit is anemia of prematurity. And erythropoietin is produced primarily in the liver in the newborn. So erythropoiesis is suppressed by improved postnatal oxygen and depressed plasma levels of erythropoietin. So anemia of prematurity is from insufficient EPO production, small circulating blood volume, iatrogenic blood loss, hemorrhage, hemolysis, and shortened red blood cell survival. Iron status is also very critical for recovery of hemoglobin. Some of the treatments that you use for anemia of prematurity are to minimize blood loss. You can delay umbilical cord clamping, erythrocyte transfusions, and making sure that they have good iron supplementation. Hemolytic disease of the fetus and newborn is an immune-mediated destruction of the fetal red blood cells by a maternal antibody. These fetal red blood cells express a paternally inherited red blood cell antigen not present on maternal red blood cells. They can be Rh, ABO, KEL antigens. There's also other antigens that also we have seen hemolytic anemia with. Clinical signs can be if you get a history that a previous infant had severe anemia, high drops, or very elevated bilirubins. History of maternal transfusion, positive maternal screening antibody, severe intrauterine anemia, early severe or prolonged hyperbilirubinemia, a positive Coombs or direct antibody test, and then frankly you see hemolysis present on your blood work. This is what sometimes we get called to the NICU and we ask for a peripheral smear. And so what we're looking for with evidence of hemolysis, there's something called schistocytes. These are the red blood cell fragments. And this smear actually happens to have some target cells on it as well, which can be a sign of an asplenic or splenic dysfunction or carrying hemoglobin C. We've seen that in all those conditions. Treatment in the case of Rh disease is we typically give Rogam to the mothers, but this doesn't always prevent the hemolytic anemia from happening, so it still needs to be on your radar. There are some cases we actually have Dr. Harmon at our hospital who does intrauterine transfusions, and so he usually consults with us well before the baby is born because it's not uncommon for them to need at least 1 or 2 more transfusions, but he does do that at our hospital. So we are involved in all those what I call high-risk obstetrical anemia babies. Phototherapy for hyperbilirubinemia. We have given gamma globulin to try the goal with that is to try to reduce the need for transfusion, but there's like a conflict of results of that, so it can delay the need for it, but they still usually typically need 1 more transfusion after birth, depending on the severity. Exchange transfusion is sometimes necessary depending on how high the bilirubin is. And then we actually recently had a case from Upper Chesapeake that presented at 3 months of age. This was a Spanish-speaking only family, and I think they were lost to follow-up, but this baby showed up needing a transfusion in our PICU. His hemoglobin was 3 from hemolytic disease of the newborn. So we still are seeing these very drastic cases, and they can present even later So you just want to have, make sure that they're understanding and that they're following up. It's just very, I haven't seen that in several years, but we did recently have a case of that.
And that child got gamma globulin afterward?
I think they just came, they presented to upper Chesapeake ED with a hemoglobin of 3, so we got them to PICU, and they did not get any treatment. Yeah. Other causes of hemolytic anemia, you can have an immune hemolytic anemia, like if the mother has lupus. I have seen that during my training. Also maternal drug intake. Dapsone is not really used that much, but it is out there, so we usually do an investigation of maternal drugs if it's not a blood group issue. Infections such as CMV, toxo, syphilis, and bacterial sepsis, you can get hemolytic anemia. Vitamin E deficiency in premature infants. Infantile pycnocytosis, which can only be diagnosed with a peripheral smear. I've seen a patient with that. Red blood cell membrane disorders can be very difficult to diagnose at birth because if they have a high retic count, you will have an artificially high G6PD, so you could miss a true G6PD deficiency. Spherocytosis, the best test we have today is osmotic fragility. That in itself is not the best test, so we also try to do some genetic testing if we suspect spherocytosis. Elliptocytosis, pyruvate kinase deficiency. We have a very good hematopathologist who helps us. We get a blood smear and look at those blood cells, because sometimes the diagnosis is basically from your heme path. We actually have a patient that was adopted from Africa, and he does have G6PD deficiency and malaria. So we do see this at our institution, and they usually are very clinically benign, but it's basically you just want to make sure that if they get a fever or they get stressed, that they have a good follow-up, because that's when the problems can rise, and they can hemolyze down pretty quickly. So we like to meet them when they're well, and so that they know how to get a hold of us if he does, or if they do get a fever. So at any point we can see them and figure out the best way to do the testing and the blood count. Thalassemia syndrome is also alpha thalassemia or hemoglobin H disease and beta thalassemia. So the thalassemia syndromes, the patient's clinical course is usually better interpreted when you know how many genes are deleted on your alpha globin gene versus your beta globin gene. So we definitely do, we have a combined hematology genetics clinic, and they help us to know the right genetic testing to do once we do the screening and see if and a lot of times we are diagnosing this not in the right after birth, but later on, because they're the patients who have a low MCV, you put them on iron, and then you're referring them to us because they're not responding to their iron. They typically have thalassemia, whether it be trait or how many genes are deleted. Yeah. Hemoglobin E beta thalassemia also, you can use hydroxyurea to treat those patients. So we are using it for sickle cell disease, and also you can use it in hemoglobin E combination beta thalassemia. Hemoglobin E disease alone we do not. Beta thalassemia alone, it depends on how many genes are deleted, but that combination, there has been some effort looking at hydroxyurea, increasing the fetal hemoglobin to reduce problems with crises and stuff like that. Gamma thalassemia is also one that exists, sickle cell disease. You can also have these unstable hemoglobinopathies. So if you have these hemoglobin variants, right, they're the bane of our existence, right? You guys get that on your newborn screen, and then you're like, what does this mean? Well, it could mean there are like thousands of hemoglobinopathies out there. So usually we see those patients, see what their hemoglobin level is, and then we look for which variant it is and make sure that they don't have co-expression of another sickle cell or hemoglobin E or thalassemia that goes along with it. But if it's FAV, then it's probably a trait. But we do like to see the trend in the patient to figure out how to help them out. And then methemoglobinemia. I just have a case of that. I trained in West Virginia where we have well water, and there was a baby that we treated with methemoglobinemia. This is, if you remember, your hemoglobin maturation. So our alpha chain is always there, the alpha. Then we have gamma, which goes down, and then the beta comes in. So your alpha and gamma make up your fetal hemoglobin. Your alpha and beta make up your adult. And so if you look here, around this 12-week mark, postnatal, is when the beta globin really goes up. So we really do try to see, I'm going to say the sickle cell patients, but also your beta thal would also be impaired with your beta globin. We really want to see them at like 2 months of age, so that we're helping to monitor for when that fetal hemoglobin goes down and the sickle cell or the other comes up. And the earliest time that I've seen a sickle cell complication was where I did my training in Charleston, South Carolina, and it was 4 months of age. So these babies came in with pretty rip-roaring splenic sequestration. So definitely, we like to see them at least by birth to 2 months of age, so that we're helping to monitor for those complications when the hemoglobin are changing. Erythrocyte disorders, polycythemia and hyperviscosity sometimes comes up with infants of diabetic mothers. We do see this, hematocrit values greater than 65. If they have chronic fetal hypoxia or acute fetal hypoxia, asphyxia, delayed clamping of the umbilical cord, and sometimes they need a partial exchange transfusion, which we typically do manually, and we do it very gingerly, but also help to get that hematocrit down. All right, moving on to constitutional bone marrow failure syndromes, and I just picked this slide because these are the top 7 that we tend to talk about when you suspect that you might be dealing with a child that has one of these bone marrow failure syndromes. I will tell you that typically the first 3 don't really manifest cytopenias until later on, but it does come up, and you might have a child with absent thumbs, then you have to worry about Fanconi's, right? And so you're picking up on these things in the newborn period, and then you're getting them to us because we do help monitor for when those cytopenias might develop, versus, we've had a patient with this, amegakaryocytic thrombocytopenia, where they need platelets from birth. They need to be transfused. They don't have any precursor in the bone marrow. They are completely dependent on platelet transfusions. And I've seen one case of that. We've also had a case of diamond blackfan anemia. This one is harder to predict, I'll have to tell you. I've seen variations of how that presents. I've had some babies present with that needing a transfusion on day of life 2 versus presenting as late as 4 months. So there's a lot of clinical heterogeneity within each of these diseases. I've had a patient with severe congenital neutropenia. They typically present before 6 months of life with severe infections like pneumonia, staph, abscesses, MRSA, and these kids, they have an ANC of 0, and you have to do a bone marrow on them to make a diagnosis. And we have had this, and it can run in families, and it can be more severe with, like, if the adult person has lived their life and never been admitted, the child actually can have more severe infections. And that's what we saw and where I did my training. Thrombocytopenia absent radii syndrome. There was recently a local pediatrician that called me that somebody had this, but I've actually never managed one of those patients. But it is always on your radar, and you always read about it for boards or when you get a consult for thrombocytopenia in the newborn stage. It's very important to try to get a peripheral blood smear, even if we don't know which one we're dealing with, because once you give the blood transfusion or platelet transfusion, I can't rely on whose cells I'm looking at. So if you ever have a question or you're suspicious, go ahead and get a peripheral blood smear, because I can always show it. I can look at it and also show it to our hematopathologist. Also, if you can send off a hemoglobin electrophoresis, you would be amazed. My patient who presented at day of life 2, we never were able to get a true hemoglobin electrophoresis because we had to keep transfusing him. He was completely transfusion dependent. He ended up having a genetic mutation which helped us to diagnose diamond blackfan anemia. Some syndromes, the cytopenias don't develop until later in life. Other syndromes, like I said, like diamond blackfan, can be transfusion dependent very early on. Many of the syndromes that are associated with actually an elevated fetal hemoglobin, higher than you would expect, elevated MCV due to stressed erythropoiesis, and newborns actually have a higher than normal MCV anyway. So we have a chart that we go by the age and the day of what we're looking at, and then eventually that MCV goes down a little bit as they get older, usually by about a year of age. Congenital anomalies may or may not be present at birth and tip you off that you are dealing with one of these bone marrow failure syndromes. And here's a very nice chart summarizing the way that these syndromes are inherited. Fanconi's anemia can be autosomal recessive, X-linked, dyskeratosis congeniti. This can be really hard, and sometimes these patients are not diagnosed until they're well into their 20s and 30s. Schwachman-Diamond syndrome, they can not be transfusion dependent, but these are your kids that, I think of it this way, they sound like a cystic fibrosis patient without having the lung complications. That's how I remembered them when I was a medical student. They have a lot of problems with failure to thrive, absorption, malabsorption. They usually are seen by our GI colleagues. And so we kind of share those patients and we try to figure out why they might have neutropenia or thrombocytopenia. They usually have a cytopenia that tips you off that something's not right. And you can have a lot of nutritional deficiencies which give you cytopenias as well. Diamond-Blackfan anemia, the severe congenital neutropenia, like I said, these kids are usually presenting very early on with ANCs of 0. They don't make any neutrophils, okay? And then your congenital amegakaryocytic thrombocytopenia, these patients are completely dependent on platelet transfusions to have a platelet count. And they come in and they have bleeding from their gums, like even when they erupt a tooth, they get massive bleeding. So you know something's not right, and then you send off a blood count and their platelet count is less than 10 because they just can't make platelets. And then TAR syndrome. So as you notice, a lot of them have some type of somatic abnormality, but they don't have to. All of these can lead to bone marrow failure. You just don't know the timing of that. There's no exact time, but they definitely need to be monitored by us. Short telomeres, your dyskeratosis congeniti patients seem to have the shortest, but they can all have telomeres that are not normal. They all tend to have a predisposition to cancer. So if they have an eligible sibling or somebody for a transplant, we do try to transplant them, depending on the clinical situation. Chromosome instability, and then some of them actually have some genes identified. So that can help you confirm your diagnosis with your clinical findings. Platelet disorders. So fetal and neonatal immune thrombocytopenia, alloimmune versus autoimmune. So alloimmune is the one that we tend to worry about a lot. This is caused by a maternal IgG alloantibody that's stimulated by the fetal platelet antigens inherited by the father. Alloimmune is characterized by thrombocytopenia and possibly bleeding in an otherwise healthy term infant. The mother's platelet count is normal, and this is key in helping to figure this out. Thrombocytopenia in the newborn worsens over the first 2 days of life. Bleeding tendency is worse in the alloimmune when compared with autoimmune. IVIG is usually what we use for treatment. I have not had to use steroids, but we always talk about it if they don't respond to IVIG. And sometimes, depending on the platelet count, the NICU attending likes to go ahead and give them a platelet transfusion. Although they can be, we try to do the PLA1 negative so that mom's antibodies are not trying to clear them out of circulation. So our blood bank typically tries to have some PLA1 negative platelets on reserve in case this does come up for you. Intrauterine fetal platelet transfusions may be necessary in severe cases, and usually delivery by C-section is preferred. This is just a diagram showing you maternal antibodies and how this causes fetal thrombocytopenia, because the baby's platelets have a positive marker that the mom has been sensitized to, and her immune system is attacking the baby's platelets. This is just a nice diagram showing you that it's very important, of course, to do a history and physical, a CBC with a blood smear, maternal platelet count, consider blood culture and prophylactic antibiotics when you have the situation of thrombocytopenia at birth. And then it basically gives you recommendations for if the platelet count's between 50 and 150, definitely want to repeat that in 2 to 3 days. If it's stable or increasing, then you could consider testing the mom for antiplatelet antibodies. And then you would want to do close follow-up either with us or with yourself, and then notify us if it's not getting better. If it's decreasing, then you'll want to continue to monitor platelet counts, and if it's less than 50, then you want to obtain a baseline head ultrasound, send off your NATE testing, which is actually done on the mom and the dad. And this is usually a send out, I believe, to Wisconsin. No active bleeding or ICH on your ultrasound. They recommend transfusing platelets or keeping the goal above 30,000. And then we typically do add IVIG. A lot of times we do have to give more than one dose. So our most recent NATE child, we had to give a total of 2 grams per kilo. So we gave 1 gram and then we gave another gram.
So what platelet count do you see in there, you want to, or you see in a newborn that would drive you towards testing the parents? I mean, because we'll see 70, 80,000 sometimes, got to figure out a reason. You test the parents for those?
I would just because to prevent, if it is on the possibility, I would go ahead and test the parents. Just because if they have future pregnancies, I do see where it can be more severe, just like with the RH, hemolytic disease of the newborn.
So what's that cutoff where you decide to test?
If you don't have a reason, like if the mother wasn't on drugs and stuff like that, I would say anything less than 100. I definitely would consider testing both parents. It's blood work from mom and dad. You can send it off. And then what they do is they type her platelets and his platelets, and they can actually see if it's actually a pretty good test. So I think it's worth screening for, just for, not so much that baby might not need, I wouldn't give that baby IVIG yet, but for future babies. The autoimmune neonatal thrombocytopenia, this is usually when mom's platelet count is not normal. So in this scenario, mom's platelet count is low, and she typically needs to be treated. Despite a newborn's platelet count in this situation, these kids actually don't have a lot of bleeding. So that's what we clinically see. They can have platelets counts less than 50, but they might have some bruising or petechiae, but they don't tend to have a lot of bleeding risk. So it's the same therapy, IVIG, but we tend not to be as aggressive with transfusion, and they don't seem to bleed as much as the patients with alloimmune. And then I've also had a case where the mom did have a lupus that was not diagnosed, and then the baby developed more than just low platelets. They developed anemia as well. You can actually see all 3 cell lines down when this situation happens. Plus you have all of your other maternal HELP syndrome, all those other things that can come into factor when you're looking at the baby's blood counts. This is just a picture of sometimes what you can see when the baby's platelet count is very low. Several areas of petechiae. This baby was born vaginally. So you can have these situations. I've had children with very large cephalhematomas that had a low platelet count, and that was the doctor's tip-off. We need to send off a platelet count because they obviously had some skin findings that were indicative of low platelets. So neonatal thrombocytopenia, you're usually looking at if it's early versus late. Early onset is less than 72 hours. This can be caused, you need to think about infections, torch, perinatal asphyxia, chronic intrauterine hypoxia, preeclampsia, diabetes, IUGR. Late onset, typical with sepsis, necrotizing enterocolitis, drug-induced thrombocytopenia, and don't forget about thrombosis, because if they have a very large clot, it will consume your platelets and will give you a thrombocytopenia diagnosis. Liver failure, decreased production of thrombopoietin has also been linked to thrombocytopenia. So when I have a case of low platelets that I can't figure out by these other means, I usually ask for our NICU to send off a thrombopoietin level, because that can sometimes tip you off into one of these bone marrow failure syndromes or something else. These are typically treated with platelet transfusion and diagnose underlying cause. This is just a nice table. This is ITP in all age groups. Consumption, sequestration, you have to think about that. The immune thrombocytopenia is at birth, we talked about, allo versus autoimmune. Infections, necrotizing enterocolitis, sepsis, and then preeclampsia, maternal drug use, and neonatal colon injury. You also have the function defects like Bernard-Soulier syndrome and Glanzmann's. These can be a lot harder to figure out, but these are your kids that are bleeding from circumcision. They may or may not have a normal platelet count. You get a blood smear and they have abnormal looking platelets. They can be large or small. And I have here's a diagram just to remind everybody in the audience what is all housed on the platelets. You have dense granules, you have enzymes, you have a receptor, and then they put the disease next to it. Like Glanzmann's, they don't have working glycoprotein 2B and 3A receptors. Bernard-Soulier has problems with these receptors. Gray platelet syndrome are missing alpha granules. Your May-Hagelin disorders and giant platelet syndromes have problems with the cytoskeleton of the platelet. And then Wiskott-Aldrich is another syndrome that is associated with eczema, immunodeficiency, and small platelets. So again, the peripheral smear can actually really help us figure out what we might be dealing with before the transfusion. So Wiskott-Aldrich syndrome, there is a genetic mutation for that. There's also X-linked thrombocytopenias, which can be similar to Wiskott-Aldrich, but they have a varying degree of eczema. Thrombocytopenia with predisposition to develop leukemia, autosomal dominant inherited thrombocytopenias with mild bleeding manifestations. So usually when we can't diagnose what the issue is, we do get our genetics team involved. And then your A-megakaryocyte or hypomegakaryocyte thrombocytopenias can be associated with your trisomy 13, 18, and 21. It's also been associated with Goldenhar syndrome, Noonan's, Turner, Gaucher type 1, Bloom syndrome, and autoimmune lymphoproliferative syndromes. So we definitely get our genetics team involved with some of the isolated thrombocytopenias because it could be telling you that they have one of these genetic mutations. Thrombocytosis, where you have an elevated platelet count. Don't see this a lot, but these kids' platelet counts are over 1 million. And sometimes we do get calls from pediatricians, and there can be a familial form, and we are screening them for JAK mutations because that can be a sign of possibly early changes with the bone marrow and a pre-leukemia syndrome. So, that's just something that sometimes that we hear about, that we follow. Unless you have a known infection, you treat the infection, then the platelet count eventually does go down. It's really hard to tease out sometimes in pediatrics because so many of our patients have viral infections, bacterial infections. Usually I see this type of response with an osteomyelitis or like a very severe pneumonia. You can see that platelet count go up. If you have a cystic fibrosis patient, they tend to have higher platelet counts. It can also be an acute phase reactant. So you really have to pay attention to the clinical situation. And if it's not going back down to normal, those are the patients that you worry about that might have a familial or some type of other thrombocytosis.
When does it get dangerous?
I believe it's 1.5 million, but we have not had to use any antiplatelet medications because it usually calms down or it drops below 1 million. Yeah. And then this is just a diagram showing history and physical exam, CBC, peripheral blood smear. Very important. Do a good physical exam on your patient. If it's abnormal, if you have lymphadenopathy or hepatosplenomegaly, then you have to think about the bad things, bone marrow evaluation. If they have congenital anomalies, then sometimes you can get your diagnosis from bone marrow or blood work from genetic workup. And then over here, we really rely on our platelet morphology to help us figure out which syndrome that we might be dealing with, or is it aplastic anemia or a congenital bone marrow failure syndrome. And this is Wiskott-Aldrich and X-linked thrombocytopenia. Those patients have very small platelets. Leukocyte disorders. There can be a transient neutropenia at birth, which is caused by maternal hypertension, donors of twin-to-twin transfusion, and then Rh hemolytic disease. So sometimes you can see some neutropenia as well. It's usually due to accelerated neutrophil destruction commencing before or shortly following birth. That you can see this with an overwhelming infection, septic shock, versus an immune-mediated neutropenia, isoimmune. So basically, the pathophysiology for this can be similar to the Rh disease of the newborn in red cells. You can have isoimmune neutropenia that's caused by a maternal production of IgG directed against the antigens on the fetal neutrophils. This can occur at any time during gestation, and you can diagnose antibodies actually in the mother's serum. So you can actually look for the anti-neutrophil antibodies in mom. This is also can be called autoimmune neutropenia of infancy. It's unclear how that one develops, but it is related to parvo B19. So parvo B19 attacks your red cells, but it also can cause a neutropenia. And neutropenia at birth in the newborn is typically not an issue for women with autoimmune neutropenia. So remember the autoimmune maternal platelets, doesn't seem to be the correlation with white cells. And then this is just some tables of causes of neutropenia. Decreased production, you can have a benign chronic neutropenia, constitutional. Kostman syndrome is another name for that severe congenital neutropenia. Fanconi's, Schwachman-Diamond, Shediac-Higashi syndrome, which is diagnosed by our smear. Benign cyclic neutropenia, post-infectious. B12 deficiency can also cause neutropenia. Leukemia, aplastic anemia, myelodysplasia, these would be diagnosed by doing a bone marrow. And then if you have increased destruction, a drug-induced autoimmunity, collagen vascular disease, isoimmune or hypersplenism. So I'm frequently asking our NICU team to get a abdominal ultrasound and make sure they don't have hypersplenism, because that can lead to neutropenia. Myeloproliferative disorders, acute or chronic infections, stress, leukemoid reactions. That's as causes of neutrophilia. Chronic inflammation, tumors, post-splenectomy, cigarette smoking, hypoxia, epinephrine, and exercise. Wow, I didn't know exercise could do that. And then there's also, we don't worry about it as much, eosinophilia, but when I see that, this is usually what you have to remember, and we're usually ruling out like a parasitic infection in those patients. So chronic hyporegenerative neutropenia is your severe congenital neutropenia. That's Kosman syndrome, Shwachman-Diamond, glycogen storage disease type 1b, reticular dysgenesis, and osteopatresis. Those have all been associated with this chronic low. They have ANCs that are very low. Cyclic neutropenia, on the other hand, they can go up and down. They can have periods of infections or not infections. They can have fever of unknown origin. Oral ulcers, gingivitis, stomatitis, pharyngitis, cellulitis, and perirectal abscesses. We've had patients present with all of the above. Shwachman-Diamond is rare, autosomal recessive with variable bone marrow dysfunction. They typically don't develop cytopenias until later on in life, but they do have the failure to thrive, exocrine pancreatic dysfunction. So usually our GI folks are seeing these patients, and then they're concerned that they might have Shwachman-Diamond, so they send them to us to help evaluate. Your glycogen storage 1b causes a deficiency of glucose 6-phosphate translocase and intracellular accumulation of glycogen. This typically presents with failure to thrive, hepatomegaly, hypoglycemia, lactic acid acidosis, as well as neutropenia, causing increased susceptibility to pyogenic infections. And then you have reticular dysgenesis, that they can have presence of rudimentary thymic lymphoid and splenic tissue and A-gamma globulinemia. So it's not uncommon for me to do screening immunoglobulins when I have a neutropenia evaluation. And then osteoporosis, basically, they don't have osteoclast function, resulting in decreased bone marrow space. So they don't have the ability to make enough cells just because they don't have enough bone marrow space. If you remember that slide about the bone marrow, they just don't have enough space. They have a narrowed space. Neutropenia is presenting late in the NICU course. Necrotizing enterocolitis is a big one, late onset sepsis, idiopathic neonatal neutropenia, and marrow failure syndromes. And in some cases, we recommend doing a bone marrow test and then starting them on growth factor. Even with the severe congenital neutropenias, you can sometimes stimulate some ANC production by putting them on growth factor. So neutrophil function disorders, phagocytic cell dysfunction. Neonates have an inherent functional defect in their neutrophils and monocytes, so they have higher rates of infection than older infants. Chronic granulomatous disease, this is where you have that deficient or absent NADPH oxidase function in phagocytic cells, and they typically have issues with catalase positive bacteria or fungi causing severe infections. So this is where, like, if you do a culture and you get back that it's a catalase positive, you have to suspect that you might be dealing with CGD. Leukocyte adhesion deficiency, severe infections and delayed separation of the umbilical cord, and leukocytosis. So I usually ask about separation of the umbilical cord when I'm seeing patients later on for neutropenia, because that can be a sign that they have a problem with leukocyte adhesion. It also, and later in my talk, can be a screening for bleeding disorders. Myeloperoxidase deficiency is usually clinically silent and suspected in severe infection with Candida. And then Shediac-Higashi syndrome, they have very different sized granules, and they can actually have oculocutaneous albinism, recurrent pyogenic infections, and they're very large intracellular granules, and you can actually make the diagnosis off of a peripheral blood smear. In some cases, and I haven't had to do it in a newborn, but in an older patient, granulocyte infusions can be used, especially if you're fighting off a fungal infection. You just have to try to give them normal working white blood cells. It's not something that you can do right away. It's usually something you can coordinate with the blood bank, but we do have the capability of doing that in our hospital. Versus doing a bone marrow and starting them on either GCSF or GM-CSF, depending on which clinical situation you might be dealing with, and then trying to get them screened and see if they have a donor for a hematopoietic stem cell transplant, because a lot of these disorders, they need a transplant to fix the problem so that they can not get all these severe infections. All right, real quickly, because I'm running out of time. Thrombosis. Most newborn infants with thrombosis have a predisposing underlying disorder and trigger. Sepsis is a very large, powerful promoter of prothrombotic hemostatic alterations, resulting in a combination of DIC and thrombosis. Catheters, babies have these catheters in. You have to think about it. It has to be on your radar. It predisposes them to thrombosis. And a renal vein thrombosis is actually very common. It happens in 22 to 44% of all neonatal thrombosis, and there's a classic triad: hematuria, palpable flank mass, and thrombocytopenia is how they can present. Cerebral sinovenous thrombosis, we get a lot of consults about that. The majority of the infants actually present with new onset seizures, and then we're getting a scan, and then we usually use MRA and MRV to figure out if they have had a thrombosis, and it usually does affect the superior sagittal sinus, so we do offer them heparin therapy, usually with Lovenox. Whereas your arterial ischemic stroke presents with seizures, prothrombotic, inflammatory states during pregnancy. You have to suspect antiphospholipid syndrome in the mother, or chorioamnionitis, and these we don't tend to treat with Lovenox. So there are some inherited thrombophilias, and the pediatricians in the room sometimes get told this by family members, that they carry factor V Leiden or prothrombin gene mutation. And sometimes I just actually saw somebody in my clinic where the grandmother was diagnosed with factor V Leiden deficiency, and her granddaughter was having heavy periods, and they're trying to figure out what birth control to put her on. So they wanted me to see if the child has the factor V. So it is out there, and we do have to sometimes argue with insurance companies, because I think you should know that as a doctor trying to prescribe appropriate hormone therapy and knowing your risks. And we tend to see a lot of teenage girls in our PICU with pulmonary embolism that have been put on birth control pills. So it is worth, checking that family history, making sure that they don't have a family history of that. And these are the ones that have been classically described. Your factor V Leiden, your prothrombin. MTHFR gene we look at that when you have an elevated homocysteine level, antithrombin 3 deficiency, protein CNS, a dysfibrinogenemia, homozygous homocysteinuria, and then sometimes really high factor VIII can increase your risk of clotting, but you have to be sure to repeat that, because that can also be an acute phase reactant.
At what age do you want to see these kids? If the parent says, hey, I've been identified as having the Leiden thing, I get that quite a bit. They say, what age should I take my kid to be tested by in the house?
Probably when they're a teenager, old enough to understand and have the blood work done, unless you really think you have an anxious teenager, and it would be better to do when they're younger. I think it's just something you can discuss with the family, but I definitely think it's something that should be looked at before they're put on birth control.
Right.
I don't know what the right birth control is to use on those patients, because there are so many new options out there. So it's something that if you're going to put them on a hormone therapy, just do close follow-up and tell them how to prevent a clot. So a lot of times when I identify a patient who's a carrier, I actually give them very good advice on how to prevent a clot to form in the first place. Also, we also have recommendations if they get certain types of surgeries where they're going to be immobilized, that you actually would put them on prophylactic Lovenox for a much shorter time than if they develop a clot, you're on it for 3 months. So it's a lower dose, a shorter time. So if you like a broken bone, an abdominal surgery, those are the types of situations where you really want to know, like an ear tube and those are not going to be problems because you're up walking around. These are situations where if they are going to be immobilized or a broken leg, a broken bone can increase your risk of a clot, even if you didn't have one of these thrombophilias. So at any time we can see them, and a lot of times this comes up in the teenage population, and it usually comes up from screening for birth control options, usually by an adolescent pediatrician or a gynecologist. All right, and this is just a diagram showing a management of neonatal stroke, which basically can be caused by hemorrhage, an arterial ischemic stroke, or an actual thrombosis. And as you can see, this is the one we typically tend to treat with Lovenox. All right, and real quickly, bleeding disorders. So we get a lot of questions about bleeding disorders, or there's a family history of hemophilia. You can send off some studies from the umbilical cord because it really takes a lot of blood and a blue top to get your factors. And von Willebrand's disease is out there. It's actually the most common blood disorder in the United States. And typically, the clinical history that we get is that mom says that she has von Willebrand's disease, and then I ask them, do they know which type? And I'm going to go to that slide. And then they look at me like I have 3 heads, because there are 1, 2, 3, 4, 5, 6 types. So normally, most people follow in the type 1. So basically, now that I've done that, how do I? It's nice if you do have a confirmed diagnosis of von Willebrand's disease, because then you actually can send off some testing if you need to. We tend to get these patients much later on because their circumcisions are delayed. And so sometimes we're doing this workup when they are 6 months of age or a little bit older to help make sure that they don't have von Willebrand's disease. Just to review how complicated the coagulation cascade is, remember this? The intrinsic pathway, the extrinsic pathway, and then you have the tissue factor pathway. And basically, if you are low on any of these factors, you can have manifestations of bleeding, which tend to occur or can occur when the umbilical cord separates, or if you do a circumcision, they can have this abnormal bleeding tendency. And that sometimes is how you see it in the newborn. This is the thromboembolic pathophysiology, the coagulation cascade, and then platelet aggregation. And basically how a clot is formed in the arteries is primarily the job of the platelets, and in the venous system it's primarily fibrin. So basically the platelets get together and call in fibrinogen, and then they start to cross-link these fibers. So don't forget, when you have a bleeding disorder, if there's nothing wrong with the platelets, you could have an abnormality of the fibrin or the fibrinogen being broken down too quickly. So that's why a lot of times with von Willebrand's disease, we use factors that stimulate factor 8, von Willebrand factor, and then also aminocaproic acid, which prevents the breakdown of the fibrinogen. So you kind of have to hit both pathways. So congenital factor deficiencies like hemophilia A, if your factor 8 is less than 1%, you are considered severe. Moderate if it's 1 to 5, and mild if it's 5 to 50. 40 to 60% of children with severe hemophilia actually are clinically asymptomatic as newborns. 50% have a bleed by the age of 1.5. They can have intracranial hemorrhage. They can have a muscle or mouth bleed, a cephalic hematoma, bleeding from the umbilical cord, and also following circumcision, but they don't have to. So them not bleeding after circumcision still does not mean that they couldn't have hemophilia, because that's not like a 100% test. Factor 9, they usually typically bleed like a factor 8 deficiency patient. You can also have afibrinogen or dysfibrinogenemia, which is why you want to include fibrinogen in your screening PT, PTT, and a fibrinogen. You can also have a factor 5 deficiency. These patients bleed very easily. That is they have a lot more bleeding. They can have gastric hemorrhage, soft tissue hemorrhage. Factor 7, they tend to present like a hemophilia patient. We talked about the different types of von Willebrand's, which we have very fancy testing, and you have to add multimers. It's not just factor 8 and the von Willebrand factor. You have to look at all of those components because it's very diagrammed out. National Heart, Lung, and Blood Institute has a very nice handout to remember all of this when you get all of your results back. And some of the labs even go ahead and give you the interpretation, which is very nice too. You can have congenital factor deficiencies of factor 10, 11, and 13. And unfortunately, they present with an intracranial hemorrhage. So whenever we have a baby with an intracranial hemorrhage, and they have a normal 8, a normal 9, then we're looking at these other factors, because that can be their only presentation. You can also have alpha-2 antiplasmin deficiency, which they also can have umbilical cord bleeding. And then you, of course, can have the acquired hemorrhagic disorders, which why is important for the vitamin K, DIC, and if a baby has liver disease, a primary liver issue, they would have problems with their clotting factors. Factor VII is the only clotting factor made in the liver, and then even thrombopoietin, they may have a deficiency of platelets because of not making thrombopoietin. All right. Thank you for your attention. I hope somebody learned something new. I wanted to make sure I had time for a few questions.